So we'll get started now. Hopefully, I'll answer all the questions that were on the quiz during the lecture. We talked about the objectives. The way I'm going to basically do this is we'll go through a case for each kind of emergency, and then we'll talk about the type of hematologic emergency the case is referring to. If you have questions throughout the way, feel free to just interrupt or raise your hand. I'll stop periodically to check in as well. So we'll start with this first case. So a 24-year-old male, he has B-cell acute lymphoblastic leukemia, is sent to the emergency room by his PCP or his GP after his outpatient blood work showed a potassium of 6.5. He received an infusion of, that's inotuzumab ozogamicin, which is an antibody drug conjugate we use here at least. And along the way, if drugs are different between what we use here or there, feel free to let me know, as well as lab values if the units are different. So we got that drug 4 days ago for the ALL, and in the ER, his CBC shows anemia to 6.8, his white cells are 1.0, he has 45,000 platelets, potassium is high again, his sodium's normal, bicarb normal-ish, a little low, BUN is 40, his creatinine is 2.8, he has an elevated phosphorus, his LDH is high, and his uric acid is 9.4. His only clinical symptom, he feels well, except he's noticed that he has some swelling in his legs that's new over the past few days. The best next steps are what? So we can give him a liter of normal saline and recheck his labs. Should we check a G6PD level, give him fluids, give insulin and glucose? Should we consult nephrology for the AKI and just wait to see what they say? Or should we tell him, you're good, there's nothing wrong, discharge him and tell him to see his GP again? So the answer here is going to be B, right? So we're going to check the G6PD level, start maintenance fluids, give insulin and glucose. And so this is leading into tumor lysis syndrome. So this is really one of the more common hematologic emergencies that we end up seeing, at least at our institutions. So we'll start by talking about how do we actually diagnose this? What do we need to actually make a diagnosis of tumor lysis syndrome? And there's two real criteria. One is laboratory and one is clinical. So it happens when you have a ton of tumor cells and they're lysing or they're dying off and they release all the contents that are inside of them into the bloodstream, right? And that ends up becoming toxic, nephrotoxic, cardiotoxic, and so on. So the laboratory diagnosis is you need two of the following within the range of treatment, right? So this only occurs after you've started treatment for the malignancy because that treatment is the one that's causing the cells to lyse. So those laboratory criteria are here. So you don't really necessarily need to memorize the numbers, but it's uric acid. So if you have an elevated uric acid, an elevated phosphorus, high potassium, low calcium, so you really need two of these four to constitute a laboratory tumor lysis syndrome. And then the more serious form really is a clinical tumor lysis syndrome. And that's when you have all the laboratory criteria, but your patient is actually starting to show clinical signs of this. So in our case, our gentleman is showing clinical signs because he's having lower extremities edema now, as well as the early signs of AKI and renal failure. So that we start seeing the signs of these electrolyte abnormalities in clinical tumor lysis syndrome. So, when you have a high potassium, you start seeing those peaked T waves on EKG. Furthermore, then you get arrhythmias. That's when it's really high. But hypocalcemia, right? You can start seeing tetany or muscle spasms in the patients. And the most common one that we really end up seeing is the renal disease, right? So we really see these AKI start to develop from the uric acid depositing into the renal tubulars. So how can we tell if our patients are at high risk for this? Because that's really part of it, is knowing, should we expect this in our cancer patients or not? The hematologic cancers are really the highest, the most common ones, especially the acute leukemias, right? So AML is by far the most common that this is going to occur in. ALL is right behind it. And then after that, some of the lymphomas, so non-Hodgkin's, like diffuse large B-cell lymphomas, can also cause this. But we're seeing more and more as our cancer therapies are getting better and better throughout the times that some of the solid tumors are as well, because if our cancer therapies are getting so good, they're killing off the tumor faster, which then is putting patients at a higher risk of lysing faster. So here we're seeing a bone marrow smear of AML, and then the other, this is a PET scan of diffuse large B-cell lymphoma. So you're going to see on the PET scan, very bulky disease. The more kind of tumor burden, the higher the risk is for tumor lysis syndrome after starting treatment. So yeah, the higher the proliferation of the cells, the more likely, and the more effective the therapies, the more likely. Okay. So a little more about the pathophysiology, kind of going back to the medical school days of purine metabolism, right? So our cells lyse and they release everything that's in them. So that's electrolytes like potassium, phosphorus, but it's also the nucleic acids from all the DNA that's spilling out into the bloodstream. And it's not the nucleic acids themselves that are really toxic, but it's once they're converted into xanthine and uric acid, right, through this purine metabolism. It's the uric acid that causes a lot of the problems. The hypocalcemia can also occur from the phosphorus binding to the calcium. And as well as a direct release of cytokines from the tumors lysing themselves. So what do we kind of see on labs? How do we monitor? How do we do prophylaxis for this? And how do we manage it once we start seeing it? So the first thing is, what do we see on labs? Well, the G6PD level is really important to get. And it kind of seems random at first. Why would we do that? But that's because if we end up having to give rasburicase, these patients cannot be G6PD deficient. Otherwise, you'll throw them into a much worse lysing crisis, right? And rasburicase we'll talk about in a second, but it's one of the medications we give that help you urinate out the uric acid. So we always check a G6PD level right away when these patients come in, just in case we need to give rasburicase. If you have somebody in acute TLS, frequent lab is pretty important. It might be a pain for the patient to get stuck so frequently, but Q4 to Q8 is usually what we end up doing for the first day or so to monitor that potassium, to monitor the creatinine, and those sorts of things. And then we also want to make sure that they're having good urine output. Normal urine output for any of us is 0.5 to 1 ml per kg per hour, but we really want to be overshooting that in these patients because the idea behind most of the treatment is just to flush all these toxins through the kidney and the renal system. And so that brings us to like how we treat this, the meds and the drips, right? So the mainstay really is IV fluids, and we want to be pretty aggressive with these IV fluids. So generally NS or half NS, normal saline, and we'll start pretty high at 200 mLs per hour, at least for a lot of these patients. Because again, we want to really make sure they're urinating flush through the kidneys. We put all of them on allopurinol, generally speaking, the maximum dose, which usually is about 300 milligrams a day. And then, if you read in the literature, some people will say just give rasburicase to all these patients right away. At least at our institutions, we don't generally do that. We'll at least wait to see how high the uric acid is. And if the uric acid ends up being around 9 or higher, then that's when we'll start considering rasburicase if their G6PD is normal, right? High phosphorus, we can give phos binders like sevelamer. And if your patients, you're giving all these fluids and they're still not urinating that much, that's when we need to start thinking about diuresis, right? To actually force them to flush through the kidneys and the renal system more. And that'd be loop diuretics to do so. Importantly, remember, don't use thiazides here, right? Because those will actually increase uric acid and you'll make it worse. And then hyperkalemia treatment, what we always do, that's like in the case before, insulin and glucose works for hyperkalemia over 6. We use Lokelma as well. And then kind of a last resort is dialysis. So this is when your patient's not making urine, the electrolytes you can't even control with all these measures. That's when renal needs to start thinking about starting hemodialysis. So we'll start with the case number 2 now. So we have a 30-year-old female. She has type 2 diabetes and sickle cell anemia. She's admitted to your medicine service in the hospital for a sickle cell pain crisis. She started on an opioid regimen and she's getting some improvement in her pain symptoms. But on the third day in the hospital, she reports having acute onset shortness of breath. Vitals, she's slightly febrile, 38.5 Celsius. Heart rate is normal. She's a little tachypnic, respiratory rate's 22. Her oxygen is 91% on room air, and her labs are showing a hemoglobin of 6.8, slightly elevated potassium, and the chest x-ray is here that we're showing. So we can go through the chest x-ray. So we're looking here, upper lobes look pretty clear. The heart border may be a little large, but really what we're seeing is kind of lower lobe bilateral opacities, fairly diffuse in the lower lobes, both sides. So when we see this patient in the x-ray, do we tell her, we tell her it's atelectasis, we give her an incentive spirometer and let her be. Do we do a rapid flu test and wait to see what it shows before doing anything else? We give her antibiotics for community-acquired pneumonia and think about giving her just a basic, simple blood transfusion, or do we consult hematology and await recommendations? I think generally the answer for all of these is never just to wait and do nothing, right? You always want to do something when you have a patient that's acutely ill. So the answer here is going to be C, right? Start antibiotics and consider a simple blood transfusion. And we'll talk about why. This is acute chest syndrome. So acute chest syndrome, sequelae of sickle cell anemia. And so this is the distribution of sickle cell throughout the world, and I'm sure we're all familiar with. In the US, we see a good amount of it, really not in the central US, but especially in New York City, we see a lot of sickle cell. So this is pretty common for us as well to deal with in the hospital. And so the definition and pathophys of an acute chest syndrome in sickle cell anemia is a new acute fever with acute respiratory symptoms, and you see an infiltrate on radiology or imaging, right? So in the chest x-ray, we saw those new bilateral infiltrates, and then you can see below, here's a CT scan of that same patient. You see the posterior lung fields, kind of ground glass, small maybe effusions, but real patchy there as well. But how does this really happen? Why did this happen to a patient who was in the hospital for 3 days and then all of a sudden she's having these symptoms? Really, there's always an inciting factor. A lot of times that's a viral illness. It can be a bacterial illness. It can be the pain crisis itself. And that just causes a sickling crisis to occur. When the blood cells sickle, then they start clogging the microvasculature. And then when you clog the microvasculature, especially in the lungs, you start to get the hypoxia, decreased perfusion to the tissues of oxygen. So like we said, infections are main cause that set these off, especially viral infections, much more common than bacterial. But if you do see bacterial, a lot of times you'll see it's the atypical pathogens, mycoplasma, chlamydia, those types of things. And then we talk about fat embolism is very rare, but it can occur in these populations. Rare, but can occur in these populations. And then in severe cases, you actually get the end capillaries of the lung infarcting. And so you get microvascular pulmonary infarctions. So the signs and symptoms we talked about a little bit. But one of the things I want you to take away is these often can occur after the patient is already admitted. They've been in the hospital for a few days for, say, a pain crisis, and then they develop it, right? Because some patients can get sick from being in the hospital or the pain crisis itself. So you see these patients, they develop a fever, they have cough, or they have a tight squeezing chest pain, especially pleuritic chest pain when they take a deep breath in. They might start wheezing. And then you start seeing their oxygen dip down, their saturation, right? And they may not be technically hypoxic, they may still be 93%, but if they came in and they're 98% on room air and all of a sudden they're down to 93, that's a difference for them, right? And like we said, we get the chest x-ray to see if there's any opacities. We really generally don't need a CT for this. It's kind of excessive. So we just get a chest x-ray. You can check the CBC to see if their hemoglobin's lower than baseline, to see if they're having more sickling than normal. as well as your hemolysis labs, right? So haptoglobin to see if they're hemolyzing, LDH. And then as far as determining the cause, we'll generally get blood cultures on all of these patients, respiratory viral panel, at least influenza, because influenza is one of the main causes or triggers for an acute chest. And then, like we said, the atypical pathogens are common. So Legionella, if you're able to do urine pneumococcus, we actually don't have it at our hospital, but many places do. Sputum cultures, I'm generally not that big of a fan of because they don't really have that great of a yield. But if they're having a very productive cough, you can try it. And this is really to help you guide your antibiotic or antimicrobial management. When we're treating this, it's a hematology consult every time. We want to keep their oxygen up because low oxygen is going to cause more sickling. So we want to keep them oxygenated. We usually put these patients on IV fluids so that we're actually increasing the hydrostatic pressure of the vessel so that those sickling cells don't clog it as easily. If the vessel's bigger, then it's going to be harder to clog an infarct. So IV fluids help increase that vessel diameter. Pain control is always very important. It's a very painful condition, especially in these crises. We give them incentive spirometry to help open up the lungs and prevent atelectasis. And then the big thing is our antimicrobials, right? So assuming these patients don't have risk factors for resistant organisms like MRSA or Pseudomonas, things like that, we'll generally treat this like it's a community-acquired pneumonia. So that kind of varies place to place, but I'll usually do a macrolide like azithromycin and ceftriaxone or any sort of beta-lactam, but I'll usually use ceftriaxone here. But if they have those risk factors for MRSA or Pseudomonas, then that's when you can do vancomycin or a piperacillin or cefepime, whatever your Pseudomonas agent is that you prefer. And we said get the viral panel, especially flu, because if they're flu positive, then you can give them Tamiflu or oseltamivir, right? And there you go. Also note, you can have both at once, right? You can have a viral and a bacterial pneumonia at the same time, and that's actually fairly common. So if they're flu positive, don't think we should just give oseltamivir. We also have to think about, do they have a bacterial component on top of that? The big kind of debate nowadays is simple transfusion versus exchange transfusion. Until 10 years ago or so, a lot of the research would say exclusively do exchange transfusions, never do simple transfusions in these patients. And the idea was if you just give them simple transfusion, they'll just continue to sickle and it's not going to be enough and it's not going to help. There's been some more research lately in the past decade that shows that simple transfusion in some mild cases is just as effective as exchange transfusion. Exchange transfusion is a pretty, I don't want to say invasive, but it takes a lot of resources, right? You need to have you need to have the exchanger, you need to have somebody who can operate it. You're using a lot of blood from the blood bank, so it's a very resource intensive thing to do. And it's a clinical decision. So these are really in the more severe cases where you're giving IV fluids, you're giving antibiotics, and they're just not improving. Their hypoxia is still there, they're still febrile. Then we need to start thinking about exchange transfusion to get rid of those sickle cells and put in healthy red blood cells. So that's acute chest. Is there any questions or thoughts on this? The next one is my favorite topic, maybe in medicine. I love talking about this one. So we'll do the case here. So 48-year-old female is in your ICU for a severe pneumonia. She's been intubated. She's been on pressors. We're trying to wean her off levofed or norepinephrine. But over the past 2 days, you've noticed her creatinine has jumped from 1.2 to 2.0. She has a new AKI. Her platelets have dropped pretty quickly from 241 to 64, and her hemoglobin's dropped a bit too, from 8.4 to 6.8. There's no signs of active bleeding. She doesn't have any melena. There's no GI bleeding signs. Overnight, though, you notice her left fifth pinky finger, the tip of her pinky finger, has become dusky, dark, cool to the touch. You get a peripheral smear, and you see that on the right here. Here's her smear. So think about what the diagnosis might be, and even if you don't know the diagnosis, what would be the next step? So do we consult nephrology for the AKI and start her on fluids? Should we give her a burst of steroids, methylprednisone in this case? Should we broaden her pneumonia antibiotics to meropenem? Maybe she has a resistant organism now. Should we switch the vasopressor from norepinephrine to phenylephrine? And so the answer here is going to be B, to give the bolus of methylpred. Broadening, really, there's not really any signs that it's necessarily a worsening infection, right? A worsening infection wouldn't really cause AKI or drop in platelets. Consult nephrology, you can consult nephrology and start IV fluids, but that's not really going to solve the platelet or the anemia problem. And then D, this might be the worst thing you can do for this patient, right? If they're already having ischemia in their digits, putting them on phenylephrine is going to make them more, that's an alpha agonist, right? So it's going to make their digits even more ischemic. So B is the answer here because the diagnosis is TTP, or thrombotic thrombocytopenic purpura. I love talking about this topic. I think it's a fascinating disease. So a little background, this is a very rare condition, right? We don't see this often, true TTP. A lot of times we always rule it out, right? Because it is one of these hematologic emergencies, but it rarely is actually TTP. It's 1 to 5 cases per million annually. But we end up seeing it here because, New York City, we have 8 million people in the city. So if you do the math there, you'll see about 40 cases a year in New York. And we're a pretty large hospital, so we end up seeing a good amount of these cases. 90% of these are going to be in adults for the first time. And we'll go into more why that is in a little bit. It's much more common in women, 2 times more common. That's probably because of the autoimmune component. Women tend to be at higher risks of autoimmune diseases and autoantibody conditions. And it's an extremely high mortality if it's not caught and treated. About 90% of these people are going to die from this if it's not treated quickly. They still have a mortality rate if we do treat it, but it's drastically lower, 10-20% with treatment. And that's kind of on the higher end. Usually they'll do fine if we treat this early enough. But that's why it's an emergency. So we'll talk a little bit about the definition here. Right, so it's another one of those things where you have to combine clinical findings and laboratory findings. So when you see these patients, right, this is a microvascular thrombotic condition. So what are going to be the clinical findings of that? Well, it's the ischemic symptoms, right? So in our case, that patient had the tip of their pinky finger was starting to get ischemic. You could tell it gets dusky, cold, eventually it'll turn black, and eventually it'll fall off if you get it real serious. But these patients, and she's intubated too, so that's hard to kind of do a good exam. But if you have a patient who's awake and not intubated, you'll start seeing they have neurologic conditions, almost like a TIA or stroke conditions are very possible with this because you're causing microthrombi. But it could be as mild as some confusion or headaches as well. And then peripheral vasculature, so like we said in the digits, and we can also see in the renal function too, if we're getting microthrombi in the renal tubules. On the lab, thrombocytopenia is really the hallmark, and it's usually severe. You'll usually see it 50 or lower, sometimes 20 or lower, very severe thrombocytopenia, and it happens pretty quickly. It's a hemolytic anemia, right? So your hemoglobin drops and your hemolysis labs will show a hemolytic anemia. And then really the key is your ADAMTS13 enzyme activity. And definitionally, less than 10% is a definition of TTP. I think it's important to note also, you can have ADAMTS13 activity less than 10% in a patient who does not have TTP, right? So that's why it's a clinical picture as well. So how does this really actually happen? So we have to go back again, kind of to medical school days and the platelet plug and hemostasis. It's a von Willebrand factor and ADAMTS13 issue, right? So our cells produce von Willebrand factor in these very large units, and they're multimers combined by disulfide bonds, and that's how they're secreted. And then in the periphery, you have this enzyme ADAMTS13 that cleaves the multimers into the single von Willebrand factor units. So normally, as you can see here, these string-like things are representing the von Willebrand factor. So if it's cleaved, you'll just have very small pieces of von Willebrand factor. If they bind to a platelet or two, it's not a big deal because it's so small, it'll just get flushed through. The problem occurs when you don't have the ADAM-TS13 enzyme and you just have these huge multimers. Then you start getting these very large clumps of platelets and von Willebrand factor, and then you get those microvascular thrombi. And then the hemolysis happens because as your red blood cells flow by, they get sheared by the thrombi, and so you get hemolysis from this as well. A little bit more about how it happens. The vast majority of cases of TTP are acquired. They're not inherited, they're not genetic. Vast majority are acquired, about 95%. That's what this kind of table is representing. All the blue is, for every 100 patients, the blue represents the acquired cases, the red are inherited, right? And the acquired cases occur because we're producing an antibody to the ADAM-TS13 enzyme. It's not a lack of production of the enzyme, it's that we're producing an antibody that inhibits the enzyme, right? And inhibits it from cleaving that von Willebrand multimer. 5% though are congenital. So these are genetic and people are born with them. It's an autosomal recessive mutation of the ADAM-TS13 gene. And in those patients, they're not producing the enzyme. So they don't have an antibody issue. It's that they're just not producing ADAM-TS13. They don't have any of it, so they don't have anything to cleave the von Willebrand factor. Another term for the congenital TTP is Upshaw-Schulman syndrome as well. You might hear it called that. And then, so how do we make the diagnosis? Well, so we kind of talked about what we see on lab, right? Your platelets are going to drop quickly. Your hemoglobin is going to drop because you're hemolyzing. You'll start seeing some renal disease from these microthrombi clogging up the renal tubulars. Your haptoglobin will come low because of hemolysis. LDH will get higher because of hemolysis. Reticulocyte count, right, should be high because we don't have a problem making red blood cells. So retic should be high to help compensate for the hemolysis. And really, we want to get a peripheral smear. This is very important here because on the peripheral smear, the hallmark of TTP is going to be schistocytes, right? To see that intravascular hemolysis, we'll see schistocytes. And so we can go through this smear. There's a lot that we see besides just schistocytes on here, but you can see it's loaded, right? So here's one, here's one, here's one. They're everywhere. TTP, you're not just going to see one schistocyte per high power field. You're going to see it loaded like this, 5, 6 per high power field. And that's what we see here. We can also see, right? So this cell, these darker and slightly larger RBCs, those are reticulocytes. So we can see that this person's trying to compensate and produce new blood cells to replace the hemolyzed ones. We don't see many platelets either, right? So maybe these are small platelets, but these could just be like cellular debris. We really are not seeing platelets here. And then we look at this neutrophil, and we can see the very kind of coarse stippling granulation in there is what we'd call toxic granulation, which often indicates a sepsis state. So in this patient, likely the TTP is triggered by some sort of sepsis, whoever smear this is. And then on the right, won't go too deep into this, but it's just our lab colleagues around the world have gotten pretty creative on how to actually test for the ADAM-TS13 enzyme activity. They use fluorophores and light emittance to test to see how active the ADAMS is. I'll say also for us in our institution, this will also often take forever to come back, the ADAMS level. We'll get it early on just in case. But at some point, if it's taking 5, 6 days, you might just have to empirically treat and assume that it's low if you have everything else that's in line. So how do we treat and manage this? Well, the mainstay is Plex or plasma exchange, right? The patient's plasma is what's going to be containing all those microthrombi, those large von Willebrand multimers that are clogged up with platelets. So really what we have to do is remove that and give them good plasma back. Then after we're getting rid of those large thrombi, well, how do we solve the problem of their making autoantibodies against ADAM-TS? Because you can exchange them all day long. If they're still making the antibodies, you're not solving the root problem, right? And so this, generally the first line is very high dose steroids. We'll use methylpred, but you can use any sort of equivalent, whether it's dex, pred, what have you. And it's high dose, so it's 10 mg per kg, generally speaking. So for a normal 70 kg individual, it's 700 milligrams of methylpred a day for 3 days. So that's, they're going to feel that for sure. And then, of course, you're going to have to taper down because it's such a big dose. That being said, sometimes that's still not enough. After that, we'll use usually rituximab, CD20 monoclonal antibody, and the goal there is to deplete your B cells so that you can't make antibodies. Of course, all of these are going to be immunosuppressive, so we have to be careful of that. Falling out of favor is some chemotherapies like cyclosporin or vincristine. We really don't use these much anymore for obvious reasons. It's toxic, it's chemotherapy. But the future of TTP is now we have recombinant ADAM-TS13 enzyme. But if you think about it, right, we can only use these in those 5% that have the congenital. So if you give these to the acquired individuals, then their antibodies are just going to block the recombinant atoms. But if it's a congenital patient who's not making any atoms to begin with, you can give them recombinant enzyme. There's some data that shows that NAC, or N-acetylcysteine, works by breaking those sulfide bonds in von Willebrand, so it breaks down those large multimers. Bortezomib is a proteasome inhibitor. We don't use this too much. And then again, the future is this monoclonal caplacizumab, which works by inhibiting the connection between von Willebrand factors and the platelets. So it blocks the von Willebrand factor GP1B bond between platelets and von Willebrand. We will basically never use this because it's insanely expensive. It costs about $8,000 per dose, and you need a lot of doses. So they end up paying, the total course with caplacizumab is about $250,000 US. So if we can accomplish all this without using that, we'll try not to use that, right? So that is TTP. Are there any questions on TTP? Yes.
Okay. My name is Dr. Dago. My first question is, what is the role of platelet transfusion in TTP? And the second question, as I have said, most of the cases of TTP are acquired and they are secondary caused by infections. So when we give high dose, which I for those patients having because of, let's say, a bacterial infection, wouldn't that be like suppressive to the immunity and the cause the infection to very similar?
Yeah. The first question was about blood transfusion, right?
Platelet transfusion.
Like RBCs?
Platelets.
Platelet transfusion, got it. Yeah, so that's a tricky one because, right, your patients are severely thrombocytopenic, so they're at a high risk of bleeding. But when that is happening, if you give these patients platelets, they'll end up getting worse, right? Not better, because they're just going to exacerbate those microthrombi. So you can give them platelets all day long, and their thrombocytopenia isn't going to actually improve, because once you give it, they're going to get bound up with the von Willebrand. They're not going to be used for hemostasis. They're just going to be causing microthrombi. So that's why we really, when treating, you have to get to the root cause, which is these antibodies, right? And flushing those out somehow. As for the second question, great point, right? So a lot of times this is triggered by some sort of sepsis or severe sepsis. It doesn't have to be, but a lot of times that's one of the big causes. So if somebody's already super septic, and we're giving them a gram of methylpred or rituximab or vincristine, are we just basically killing their immune system and letting the infection run its course and run rampant, and it's going to kill them? You know, I mean, that's definitely a possibility. It's kind of one of those things, there's no great answer. It's what's gonna hurt the patient or kill the patient first, right? The sepsis or the TTP. So at the end of the day, that's why, you know, if you're really concerned about the sepsis, I would try and manage them first with the plasma exchange, maybe exclusively, to kind of give that temporizing, right? It's not going to do anything for the root cause because they're still going to be making the antibodies against atoms, but you might be able to stabilize them with the plex or the plasma exchange. And then you can try some of these other options like N-acetylcysteine, and you can try and treat the infection in the interim to get it under control so that you can then do one of these options. But I agree with you, there's really no great solution to this because we see that often. You know, like the patient in the case we discussed, you have a severe pneumonia, and if we don't know the exact organism, or let's say it's a resistant organism, even if we're giving them antibiotics, then we flush them with rituximab or steroids, then the pneumonia is just going to take over and then they're done, right? So I agree, there's no great answer, but that's kind of what I would say is temporize until you can get the infection under control, and then you can go forward. Any other thoughts on this? It's still morning in New York, so I'm having coffee. All right, so the fourth, we're doing okay on time, good. Case number 4. Now we have a 32-year-old male. He's healthy, doesn't have any past medical history. Comes into the ER for shortness of breath for a day or so, let's say, and some blurry vision. You get a CT angiogram of the chest because you're worried he might have a pulmonary emboli. It doesn't show any PE, but it does show some moderate bilateral edema, pulmonary edema. Then because of the blurry vision, you get a CT head. A non-con CT head doesn't show any intracranial abnormalities. And your CT scan your CBC shows anemia with a hemoglobin of 8.1, a leukocytosis of 64,000. His platelets are 41, and his smear is shown on the right. So this is a scary situation, right? A young guy who clearly has an acute hematologic disease going on. So what do we do here? Do we immediately admit him to the ICU for leukapheresis? You check the G6PD, peripheral flow cytometry, give hydroxyurea and prednisone? Or are you worried that he's having another microthrombi event and we start a therapeutic heparin drip to try and anticoagulate him? Obviously, I wrote this question so I know in hindsight what the answer is. This was a patient I did see. But you know, when you're seeing this patient for the first time, I could understand you really doing any of these. There's no clear diagnosis yet. But for the sake of the question, it would be B, right? And we'll talk about what this is. So this is now blast crisis, or leukostasis, or hyperviscosity syndrome. I've kind of lumped these all together because they're very similar etiologies, and the managements are also fairly similar. So we'll talk about some few definitions first. So the definition of leukocytosis we know is just an elevated white blood cell count. Hyperleukocytosis is when your white blood cells are over 100,000. So hyperleukocytosis. Leukostasis is a clinical syndrome, and that's what we're going to talk about. And you don't necessarily need a hyperleukocytosis for leukostasis. Blast crisis is leukostasis that's caused by blasts. And then finally, the hyperviscosity syndrome is a pretty similar picture to leukostasis, but it's not necessarily driven by blasts or a blood component. It can be caused by protein, or, you know, we see that sometimes in myeloma or amyloid, right? So it's not just white blood cell driven. So we'll talk a little about the pathophys of these conditions, blast crises, leukostasis primarily. So it's in the name, right? So it's microvascular stasis. And what happens is you get this tremendous proliferation of these very large cells, cancer cells in this case, essentially blasts. blasts, right, are our early myeloid precursor cells, so they're bigger, so they clog up more space. But also because they're cancer cells, a lot of times they're more rigid, so they are not as malleable, they get stuck easier. And so that all of these large cells that are more rigid end up causing the blood viscosity to increase. And what also ends up happening is a lot of times these leukemia cells will overexpress surface proteins that attach to the cell wall, the endothelial wall as well. So you really have like this trifecta of large cells that are rigid, that can't fold to fit through small vessels, that are also expressing proteins that want to attach to the endothelium, right? So you don't necessarily get thrombi, but you just get a lot of viscosity and clogging and slow moving of the blood through the vessel. And because it's cancer, right, there's always going to be an inflammatory component in an acute cancer. So we have a lot of cytokines and pro-inflammatory things being released too from all these cells. So a big takeaway here, and I think this was one of the questions on the quiz as well, was the relationship between blast crises, leukostasis, and the leukemias, because this is when you're going to see it. We really need to think about, like we said, so what leukemias have the largest cells and what leukemias have the most rigid cells. So our myeloid cells generally are going to be bigger than our lymphoid cells, right? Neutrophils are bigger than lymphocytes. That's the way I think about this, right? So myeloid leukemias are going to be higher risk than lymphoid leukemias. That being said, our acute leukemias are going to be more high risk for this than our chronic leukemias, right? So that's why the most common by far is acute myeloid leukemia, right? So you're having these huge myeloid blasts in large numbers secreted that are clogging up the arteries and the capillaries and the vessels. The important thing is these cells are so big and so much more rigid is you don't actually need a crazy high white blood cell count like 80, 100,000. You can see blast crisis and leukostasis and AML with a white blood cell count of 40,000. You know, it doesn't have to be some insane number. So that's another big takeaway here. Then after that is ALL, right? So an acute leukemia is always going to be more high risk than a chronic leukemia, but it's behind AML because lymphoid cells are smaller than myeloid cells. And then you get your chronic, so CML, pretty rare for this to happen in either chronic leukemias. And then CLL is extremely rare. And like it says here, your white blood cell count to have leukostasis or blast crisis in CLL basically has to be over 1 million. So it's extremely rare to see in CLL. CML, it's also very rare. The only times that I've seen it in CML is over 100,000 by far, really. So let's talk a little more about the signs and symptoms here. Right, so it's obviously the WBC, right? So we're going to see how high is their white count, but also this is one of the times on the CBC where you want to pay attention to the differential, right? Is it showing mostly immature myeloid cells? Is it showing mostly lymphocytes? Now our differentials are not perfect, right? A lot of times they will misinterpret cells. So you cannot take that as a perfect result and assume that, oh, it's showing a lot of myeloid precursors, that this is a myeloid leukemia. A lot of times those differentials can misconstrue that. Then we're going to look for clinically, right, signs of this microvascular ischemia. It's not necessarily ischemia, but you have those same sort of symptoms because you're just getting decreased or slower perfusion from the high viscosity. So a lot of times we'll see that in the pulmonary system, as shortness of breath. That's why our gentleman, I think we said the CT showed some pulmonary edema. You can see the infiltrates on the chest x-ray, he gets hypoxic, and you actually can almost see a mimic of ARDS, or acute respiratory distress syndrome. Another system that we see this a lot is the neurologic system. So a lot of times you'll have headaches. Again, it can be mild, like the TTP patients, or it can be serious, more like stroke sort of symptoms, or TIA, transient ischemic attack symptoms. You get some blurry vision, headaches, dizziness, confusion. That's common to see. Fevers as well. Remember, this is a cancer, right? Cancer itself can cause fever. Chest pain, if this is causing a sort of myocardial infarction type picture. AKI or priapism as well. And so in the case of the case that we discussed, this is a new acute leukemia coming in. So it's not uncommon, and this is something that you may see in the office as a GP. You see this from time to time, unfortunately. So this is an urgent hematologic workup right away, because it's really what we'll end up seeing is in the management is we really want to treat the specific type of hematologic malignancy that's going on here. So a lot of times we'll send the peripheral flow cytometry right away, because that's going to be much more accurate than the differential to tell us what kind of cell this is originating from. And then, of course, a bone marrow biopsy to see what's going on in the bone marrow. That's what we're seeing here is a marrow showing blasts, and these little arrows are showing the ore rods, which indicate a myeloid lineage. You can see those extracellularly too sometimes, but a lot of times you'll see them on the periphery of the cell, which will indicate a myeloid lineage leukemia. As far as the management goes for this, like a lot of these, we're going to need to monitor closely for TLS, right? So if you have a large tumor burden, this is one of those cases, you have a large tumor burden, you have 60,000 acute myeloid leukemia cells. If you reduce those quickly, this person's going to go into TLS. DIC as well, also has high risk of DIC. There's a bit of controversy in research and clinical medicine on IV fluids for these patients. On one hand, you think, well, if we give them IV fluids, is that going to dilute the white blood cells? Is it going to kind of open up the vessels a little more to help things pass through? The answer is yes, it might do that. But we're seeing these patients already have signs of kind of hypervolemia and volume overload, especially if they have things like pulmonary edema. So could giving them IV fluids just exacerbate that and make it worse? It's kind of a tough situation. There's no real right or wrong answer. Unless they're in like florid pulmonary edema, I would generally lean on the side of giving them some fluids at least to try and temporize this again. But then the mainstay really is going to be targeting the specific malignancy that they have, which a lot of times can be tough, right? Because our tests that we use to diagnose the specific malignancy are marrow and having the pathologist look at the slides and running flow cytometry and doing genetic analysis. This takes time, right? You're not going to get this same day and start and diagnose AML immediately and start 7+3 treatment. So how can we temporize this? Well, we can at least try to tell what lineage the cell is coming from. Whether it's a myeloid or a lymphoid lineage, right? So if it's a myeloid, a lot of times we'll use hydroxyurea or hydrea. This works very well on myeloid cells and can rapidly cut down on the myeloid cells in the peripheral blood, as well as the marrow, by interrupting DNA replication synthesis in those cells. The dosing can be kind of tough, so you want to make sure that you're doing your tumor lysis precautions on these patients, because you can bring them down again from like 65,000 to 5,000 WBCs in a day or two, and then that's going to be a lysing situation. If we think it's more lymphoid, that's when steroids are much more helpful. So we'll also often use a high dose dexamethasone in these patients, but any sort of steroid can really help reduce the lymphocyte population. There's also cases where we can kind of just use a broad chemotherapy that targets a lot of different heme malignancies. So cytarabine is something that generally works well for most hematologic malignancies and acute leukemias. So we will use that sometimes, especially if we feel it's more acute myeloid leukemia, because we're going to use cytarabine anyway in most patients with AML. So that can rapidly reduce both myeloid and lymphoid lines, but obviously that comes with the toxicity of chemos, right? And then the big thing also that we talk about in blast crises and leukostasis is leukapheresis. So somewhat controversial. So the idea of leukapheresis is like we show in the circuit, right? We take the blood out of the patient, we centrifuge the large white blood cells out, and we return what we can to the patient. In theory, it sounds pretty good, right? We're just basically filtering the leukocytes or the white blood cells out, problem solved. The problem is it doesn't really solve the underlying problem, which is that you have an active acute leukemia. So you can take out the white blood cells all day long. The bone marrow in acute leukemia is just going to keep putting them out there. So you're never going to come off leukapheresis if that's all you're doing for this patient. You still need to try and target some sort of underlying treatment for the underlying malignancy. Another thing is, leukapheresis is associated with high rates of DIC when used in APML, or acute promyelocytic leukemia. So if you're worried about APML in a patient, it's probably not worth taking the risk of putting them on leukapheresis, because we know APML is also one of those cancers where it has a very high DIC risk by itself. And if you put them on leukapheresis, they're going to go into even worse DIC. So you have to be careful with this kind of when choosing your therapies. So are there any questions? That's it for blast crisis and leukostasis. Any questions on this? All right, I think this is our last one here. So our fifth case is a 68-year-old gentleman. He has kind of the usual comorbidities, right? Hypertension, hyperlipidemia, high cholesterol. He has prostate cancer, fairly high grade, Gleason 8 prostate cancer. He comes to the ER with new acute low back pain, and he's having difficulty urinating for the last day or so. He just tells you he hasn't urinated in 7 hours. He's not sure, maybe he's just dehydrated. He doesn't have any incontinence, so he can control his urination, but he's not able to. He can't really walk more than a few steps due to weakness in his legs. On your exam, you do your reflex exam. His patellar reflexes are brisk. He has some decreased sensation over the calves. So what do we think here? Should we just provide him a lumbar back brace and tell him to do some physical therapy? Are we worried that he's having a stroke? Should we do a CT head without contrast and see if he's having a stroke? Do we want to obtain a stat MRI lumbosacral spine with contrast? Or should we give him some pain medicine and reassess his pain level in a little bit? So the answer here is going to be C. So he's having some red flag signs, right? So we don't want to just give him a brace and tell him to do PT, because he'll be back and maybe he'll be paralyzed when he comes back tomorrow, right? CT head, not a terrible idea, but a little unusual to have kind of bilateral lower extremity weakness in a stroke in the brain, right? Giving him pain medicine, sure, that'll help his pain, but you have signs other than pain here, right? He's having reflex problems, he's having weakness. That's not going to solve that. So really we want to see what's going on in the nerves that are controlling his lower half. So as you might think, this is Cauda equina syndrome. I threw this in here technically, I guess technically not a hematologic malignancy, usually an oncologic or solid tumor malignancy, but we do see it. So there's really no universal definition of Cauda equina, right? There's not really objective measurements. It's not something you see on lab. There are imaging findings, but there's still not really a universally agreed definition. But generally speaking, if you look in the literature, the consensus is that you have some sort of lower extremity, sensory, and or motor loss. But the real key thing is having bowel or bladder dysfunction. And this is all due to compression of the Cauda equina in the lower spine, in the spinal canal. The real key here is the bowel bladder dysfunction, which doesn't necessarily mean incontinence, right? Losing control, but also retention. And that's actually what we see most of the time first in these patients is urinary retention, not necessarily urinary incontinence. True Cauda equina syndrome is pretty rare, so we really only see this 5 to 10 times per million per year. The most common cause isn't a malignancy, is actually disc herniations in the vertebral discs. It's fairly higher risk in those. If you think about it, a lot of patients will have disc herniations, 2 to 3% of those having Cauda equina. That's a good amount of patients. So it's something to keep an eye out in that population as well as your malignancy populations. So like we said, it occurs when you have a manual compression of the lumbosacral spine, right? It's in the name, Cauda equina, causing kind of ischemia of the nerves and cutting off the nerves, causes venous congestion. Then you get an inflammatory response from the pressure put on the spine. And that's what we're seeing here, right? So we're seeing the sacrum here. So this is your L5, 4, 3, 2, 1. Your Cauda equina is right around here at the L1 vertebra. And then we come down and we see, in this case, it looks like it's more of a disc than an actual mass or tumor. You can see that disc has sort of bulged and herniating out and pressing at the L5-S1 level. So like we said, mostly herniated discs, but we see this with tumors and malignancy. So in our case, with the gentleman with prostate cancer, right, where's the number one place that prostate cancer metastasized to? Well, it's the bone, and it's usually the low back, the sacrum, and the lumbar spine. Generally, you won't really have an exophytic lesion from prostate cancer, but it can happen, right? We can also see this from infections and abscesses. An epidural abscess can press on this. Trauma, of course. Hematomas. So a lot of times, we've seen this in patients of ours that have had low back surgery, and they come back a day later and they have a big hematoma pressing on the cord from the surgery, some post-op bleeding that was hidden. And then, of course, our elderly patients who have spinal stenosis, that itself is going to pinch eventually. So this is also where we kind of go back to anatomy in medical school, right? And our dermatomes, myotomes, and all that good stuff, right? So it's a dermatomal distribution. So the Cauda equina is below L1, so our lumbosacral nerves. And we're looking, the main thing is our bladder and bowel. The sacral nerves are controlling our bladder and bowel function. So that's why we have urinary retention and incontinence. Usually retention comes first. So, don't just ask, do you not have control of your bladder? Ask them when actually the last time they urinated was. If they tell you, like the gentleman, well, it wasn't this morning. It was this morning, and this morning was 8 hours ago. That's a problem. The saddle paresthesias is kind of one of those buzzwords we think of, right? So when you're concerned with these patients, we're always going to have to do a digital rectal exam to see if they have sphincter tone and they have control of the sphincter tone. And then the lower extremities, right? So we're testing for lower extremity weakness, whether they have sensation, their reflexes, that sort of thing. And then finally, the MRI lumbosacral spine with contrast is kind of the gold standard, right? We want to do with contrast so it'll show any sort of tumor or disc pathology. But if that's not available, CT myelogram is pretty good as well, and you can do that too. That'll at least give you an idea of what's going on there. And so the treatment, if you have true Cauda equina, remember we said true Cauda equina is fairly rare, but it's a surgical emergency, right? You're not going to permanently fix this with anything medically. So this is one of those things where you wake neurosurgery or spine surgery up in the middle of the night to come see the patient. And they may yell at you, but you're doing the right thing by calling them. Most literature says they should have surgery within 48 hours. But that being said, you still want to get the surgeon to see them right away, right? So target within 48 hours surgery. And then in the meantime, you can try and temporize it medically, depending on what's causing it. If it's a disc causing it, there's not much you can do medically that's really going to help this patient, right? No medication really reduces disc herniation that much. Maybe you give them something that's anti-inflammatory, but probably not. But if it's an abscess or some sort of infection, give them antibiotics to treat the infection. If it's an abscess, that's not going to treat the abscess, but you can treat the infection. Or if you're having a hematoma, you want to make sure that it's not continuing to expand. So do you need to reverse any anticoagulation? What do you need to do there? But the one thing where you can treat medically, at least temporarily, is if it is a tumor, right? So if you have a tumor pressing on the cord, a lot of times we can shrink that down with higher dose steroids. For CNS tumors or anything that's metastasized to the CNS or the cord, we'll usually do dexamethasone. Generally target 20 to 24 milligrams per day. So I'll usually do 8 milligrams every 8 hours, 12 Q12, that sort of thing, to shrink that down until neurosurgery sees them. Any questions on Cauda equina? All right. Well, it's been an absolute pleasure, guys. Really happy to have been here. Thank you, Abraham and Elevate for having me. This is my contact info. If any of you ever want to talk offline, happy to do so and work on anything or help you out with anything you may need. Feel free to screenshot or take a picture of this slide, connect on LinkedIn or Twitter or X, email me, whatever you'd like. But it's been a pleasure and thank you guys for having me. I hope it was useful. So thank you, everybody.